So let's talk about oral ulceration today. And I've got lots of nice photos for you today. Okay, so we're going to get ulcered out. So what is an ulcer? The definition of an ulcer is a break in the epithelium. Okay, now sometimes people prefer to call superficial loss of the top layers of the skin. They like to label that an erosion. But honestly, it's actually very difficult to distinguish. So I'm very happy for you to call basically any break in the epithelium, no matter how sort of extensive the ulceration is. I'm happy for you to call that an ulceration. So we've got this split down, which comes from the textbook about what actually happens when we get ulcers. So you can get ulceration because something has actually physically broken up the epithelium. You can have breakdown of the epithelium. We've been learning about kind of some of these processes. So you can have splitting within and trauma to the epithelium itself. You can have an inflammatory process that leads to thinning of the epithelium and eventual breakage. You can have vesicle formation, so fluid-filled vesicles or bullae, which actually then lead to the roof degloving and revealing an ulceration. And you can have other sort of abnormal growth processes which can lead to thinning and breakage of the epithelium, which we're going to talk a bit more in the lecture after this, okay? But really, you can have breakdown of any part of the oral epithelium right down to the submucosa. So over the last little while, we have been talking about lots of different causes that can lead to the breakdown of epithelium. We've been focusing on infective causes that are perpetuated by infective agents. We've been talking about inflammatory diseases where the immune system is leading to the breakdown of the oral mucosa. We're going to talk about neoplastic processes today and touch on traumatic stuff and some of the other weird and wonderfuls. Okay, so we're going to kind of focus on what we haven't really talked about or will not be talking about in the second half of this afternoon today. And the important thing, I guess, of remembering this is what we call a diagnostic sieve. So we're kind of categorizing the possible pathogenesis of what we're seeing clinically, because the patient's not going to walk in and be like, I have an inflammatory ulcer, or, you know, my ulcer, I have this lump that is caused by a neoplastic process. They're just going to have an ulcer, and in your head, you want to kind of like quickly go, your brain's going to kind of be going through the sieve of what do I actually think could be going on here, okay? So that's the way that we kind of put together all of these sort of weird processes that we've been talking about very separately for the last little while, and also kind of how you're going to be approaching your cases next year. Okay, so what's really important about thinking when you see an ulcer, because different processes can look very, very similar. We've got two ulcers that are coming on the lateral border of the tongue. And you may think it's something as simple as, oh, it got rubbed. Or it could be a process such as there's actually a malignancy there that's led to the break of the epithelium. Now, how do we actually get to our conclusion about that? It's really me seeing this appearance in a patient's mouth and then saying, oh, well, you know, I just had like the hottest piece of potato yesterday. I tried to make my own fries and I just, you know, wanted to test it and I just completely burnt my tongue. Otherwise, is very different compared to someone saying, I didn't even know that was there. I've just been biting it a little bit, but, you know, I didn't even know it was there. I've noticed that I've been biting my tongue a little bit more in the last few months, but I haven't really noticed it there. So that chronicity is really going to give us an idea of what processes could be happening there, okay? So some questions we might ask when someone presents with an ulcer or broken skin include, does it come and go? So, you know, does it sort of come and go? And if it comes and goes, does it come back in the same location? Does it sort of pop up somewhere else? Do you only get one ulcer, or can you get a bunch at the same time, okay? And where do you get it? Do you get it in areas which, you know, you're going to bite, right? Or areas where biting just doesn't explain what's going on? Do you get any problems in other parts of your skin? Have you noticed ulcers anywhere else on your body? When you get the ulcers, do you feel unwell? Do you feel feverish? Have you noticed anything other symptoms that come along when you get these ulcers. All of these parts of the history can help us to determine what processes might be happening, and for you to maybe touch on some of the conditions that we've talked about in the last few weeks. Here, there's lots of different algorithms, okay, and the key is to get your head around, firstly, the general categories of ulceration cause, okay? And we don't need you memorizing this chart or recreating it, but this is kind of what's happening in your head, okay? So this chart's great because in particular it talks about, has the ulcer been there for more than 2 weeks? We kind of use that 2-week mark because we know that that's usually how long the oral epithelium will kind of regenerate. So if you've got a traumatic process where the contributory trauma is removed, we should see healing of that epithelium at about the 2-week mark, okay? Even with like having a tooth removed, we're actually going to see complete reepithelialization pretty quickly. So 2 weeks. Now remember that if so we're still considering maybe there is still a traumatic process that's perpetuating, so the traumatic cause, like a sharp tooth, is still there, or any of these other possible causes, okay? Does that project really well on your slides that you have, by the way? Can you see that? Yeah, good, okay. All right, so let's talk about traumatic ulceration. So traumatic ulceration can look really, really scary, okay? But the key part of the history is that we want to be able to identify a traumatic source, okay? So like something that has actually traumatized that area, something that can explain why the skin would be broken, all right? We need to bear in mind that often if there's another process there, sharp teeth can make, say, a neoplasm look scratched and worse. You put it all together. But the key is that if this has really popped up within the last 2 days, my algorithm for what it could possibly be is completely different than if it's been there persisting, okay? So these are a couple of examples of young people, except for a young person and an older person, but you can kind of see that sort of jaggediness of the lower incisors. You can have people who really like to run their tongue over their teeth, which can lead to a chronic ulceration. But it might not be quite so clear-cut as that. And what I usually say is when you're smoothing teeth, and don't be afraid to smooth a tooth. I know it's like heresy, but remember that your finger's not as sensitive, especially a gloved finger, is not as sensitive as the patient's tongue, okay? So if it doesn't feel smooth to your gloved finger, there's like no hope in the world that it's smooth to a tongue, okay? So remember that as your like guide of, is there still a really jaggedy, sharp corner in there? So one of the treatments that we do when we suspect it could be trauma is to actually smooth the tooth or remove the cause, okay? Here's another example of a trauma. So this is not a frictional type of trauma, or frictional cause of ulceration. This is actually a chemical cause of ulceration. Someone probably having a very sore tooth, thinking that if they just sort of open a capsule of aspirin in there, that'll help. Doesn't work. And then we've, of course, got our extreme traumatic ulcer, also known as an eosinophilic ulcer. There are lots of other, you can see perpetuating ulcers if you don't remove the cause, but one form of ulcer that sometimes crops up and looks very scary is called an eosinophilic ulcer, in which when you biopsy, you can see lots of eosinophils, which are these white blood cells which have that actually pick up the eosin very strongly. Therefore, they're called eosinophils, and they all look really pink or red, okay? And they're not usually found in high numbers, and that's why we call it an eosinophilic ulcer, or its other nickname, which is TUGSY, okay? It looks really scary, and it is a cancer until proven otherwise, okay? So until we see that there's no cancer, we see lots of eosinophils, our main differential for that would be it could be squamous cell carcinoma. So that's trauma. I want to talk about drug-related ulceration, which is, it's actually a very gray area because it can often be quite difficult to pinpoint whether what we're seeing is drug-related. There can be causes of ulceration which are not directly related to the drug, such as with methotrexate. So methotrexate is definitely a medication that is known to be associated with oral ulceration, but we actually think that it's probably more related to the effect of methotrexate on folate metabolism, okay? Which is why it actually is a hematinic deficiency ulceration rather than a sort of non-specific drug-related ulceration in some ways, but happy for it to be called drug-related ulceration. This is why if you ever meet someone who's on this drug called methotrexate, which is it's a immunosuppressant, so people who have rheumatoid arthritis or maybe Crohn's disease might be on it, they often will be taking it once a week, and then they will take folate every other day, okay? So they'll take folate for 6 days of the week, and then they'll take the methotrexate on one day. And a number of drugs can actually lead to folate deficiency. And here, we talked a little bit about how B12 and folate are important for DNA and nucleotide formation, but here's just a little bit more detail, okay? So this is where folate is actually required to lead to the synthesis of important components of DNA and RNA, and this is where methotrexate might actually impact its not sort of specifically folate, but the change of folate to its metabolites so that it can become part of this process, right? I don't need you to memorize those, just to explain. Okay, and so there are lots of drugs that are associated with ulceration, and yes, again, we don't know exactly, is it something to do with their impact on impact on the skin's ability to regenerate or impact on the formation of the building blocks of skin. We have in this category immunosuppressants, so anything that's used for a inflammatory disease, including some that you know about, and of course we know those that are used for chemotherapeutics or cancer fighting are definitely associated with ulceration, immunomodifiers, and here's the list of some more common medications that might be used every day. Here is a medication that is a chemotherapeutic agent, which is it's an mTOR inhibitor, and these are particularly associated with oral ulceration that actually look fairly what we call Aptus-like, which we're going to learn about now. So remember, we're talking about that sort of nice, sort of rounded, with a yellow base and a red margin. They actually do look quite Aptus-like, but because somebody is on an mTOR, it may be labeled as a drug-induced ulceration as opposed to an Aptus-like ulceration. Okay, what we're going to learn about for majority of the rest of this lecture is this funny condition called recurrent aphthous stomatitis. Now, lots of people like to call it recurrent aphthous ulceration, and that's because every few years the people get bored and decide they need to rename something, and they just make an argument about how the name's not right and how they want it to be called this. And so for a while when I was going through, it was like, oh, it's so bad that it's called RAS because it's not, the mouth isn't actually inflamed, we should call it ulceration. And then there's kind of been a return of people who are like, look, we just can't be bothered changing it. So I just still call it RAS, but you may see RAU, and most of the historic literature and actually more modern literature will still use RAS, okay? So they are the same thing. Now, you've heard me use the word aphthous ulceration a lot, and this is what we're really going to dive into today. I've highlighted that it has this extra H, which everyone forgets, okay? So that is actually what I often look for when I'm looking at marking papers, because after you read 50 papers about RAS, a missing H begins to really irk you, okay? So don't forget, I've highlighted it there for you, okay? And so sometimes we call aphthous ulcerations aphthy. So when we talk about aphthous ulceration, or doctors talk about aphthous ulceration, what they are referring to is a fairly well-defined ulcer with a yellow fibrinous type base, okay, and an erythematous halo, all right? And this is just an example of how in this condition you can get complete resolution of the mucosa where there's sort of no hint that it was there before, which is characteristic of different types of RAS, but not all, okay? So RAS is very common, and it is much more common in certain age groups. And it tends to get better as we get older. So people who tend to have it when they're young, majority of them it will slowly drop off with age, and people sort of stop complaining about ulcers as they get older. Very high frequency in student populations, okay, and it comes on a lot with stress. So it's probably a number of people in this room may have experienced aphthous-like ulcerations. Does anyone want to put their hand up? They've had an aphthy? Yeah, so that's a bit lower. I'm sure someone in here is not admitting, but it's fine. Okay, so anyways, yeah, they tend to get better with age, and there are sort of anecdotal comments regarding its higher prevalence, but really it's right across the board. We don't really know why people get it, but it can sure be a nuisance, and they're very painful and can really impact your eating ability, tolerance of food, and even enjoyment of food, really. So there's lots of different associations present, and we're going to just talk about a few. So at the moment we're talking about, because there's another list of associations, but what we're talking about here is cause, not exacerbation, okay? So this is cause. So it does tend to cluster in certain HLA types, and it tends to pop up. There seems to be a correlation in twins as well, so that seems to be important. So more than one person in a family can have this condition and relate to each other. We don't completely understand why it happens, but it is associated with multiple aspects of immune dysregulation. In particular, it does seem to show a cytokine profile which is more associated with a T1 helper response. So as we remember, Th1 is more associated with autoimmunity, whereas Th2 is more associated with allergy. And then, of course, we've got the Th17, which probably wasn't really talked about in this review at all. But it seems to be much more of a autoimmune type cytokine or chemical signal profile, which kind of does make sense. There has been lots of theories and questions regarding association of recurrent ulceration with aphthous ulceration with microbes, and that definitely does make a lot of sense because the thought process makes a lot of sense because of the question of, isn't it just like herpes? Like, isn't it just the same thing? Maybe there's a bug that just like pops up. Doesn't it make sense? But there's not actually been any evidence to support that, and they do look clinically different, except for this one thing that I'm going to show you later. But there have been suggestions that, for example, there is a association with H. pylori, which is a tummy bug, which is the known cause of stomach ulceration. But they suspect that maybe it's more due to B12 absorption as opposed to specifically associating with a causal bacterial causality. So there's no real strong evidence for infected etiology, which, and those sort of studies were very, very popular earlier in the day. There's also a thought that maybe it's all sort of set off by micronutrient deficiency, and there's been some favorites. B12's probably been the one that's had the most sort of kick behind it, but it's gone through different phases. There's not really a very strong correlation with this. So I've just sort of commented here, well, if you identify a hematinic deficiency, is it really is it really RAS anymore? Because the definition of RAS is that it's kind of unknown. So if you actually know that it is a hematinic deficiency related ulceration, doesn't that just become a hematinic deficiency related ulceration as opposed to a RAS? So maybe it's not. They're kind of very separate and separate populations in different conditions. Okay, other factors, we know that it is definitely correlated with stress, but the thought here is, does stress actually commence them? And I guess the challenge with that conclusion is the fact that it affects younger people and as particularly students, and has that anything to do with stress, or just the fact that they're fairly coincident findings in that population? And then talk about food allergies and smoking as well. Okay, so there's different types of classifications of RAS: minor, major, and herpetiform, as well as simple and complex. So those are, sorry, I should have put like a line through there, but you can have, so what we can have is a minor simple, or like a minor complex, or major simple, major complex. By far the most common presentation is minor. I'm sorry that those dot points happen to go so far to the left. I'm not sure what's doing that. Okay, minor is definitely the most common. So 80% of people have minor, okay? And most of the people in the room who have experience at this ulceration will have minor. So they're little, okay? They're less than a centimeter in diameter, and they can crop up in like little bunches. Sometimes it's just one, but you can have up to 5. They are really typically round. You've got your erythematous border. They like to go on non-keratinized mucosa, so the stretchy stuff, okay? Very rarely gingiva, very rarely palate. It's more usually buccal mucosa, labia mucosa, soft, squishy stuff. Okay, and these are the type that last typically less than 2 weeks. They're usually really painful for 2 to 3 days, and then they go away and they don't lead to scarring. That is quite different from major, which probably presents in about 15 to 20% of patients with RAS. And these are big ones, so they're big whoppers. And they really like to go in annoying places like the soft palate, okay? And they are whoppers, and they heal with scarring, okay? So they can be scars there. And thankfully, this is relatively rare, but they do hang around and make people really miserable. And then we've got this funny form, which is really, really, really rare. There's only one person that we have seen in the clinic who has this, and she's actually one of the specialists because it's very rare. And so this looks very herpetic, so it's like someone just keeps getting a crop of herpetic ulceration every now and then. The key is it's not associated with fever, and it doesn't follow a dermatomal pattern, okay? So it really is just these random small pinhead-sized ulcers. They are not preceded by vesicles, okay? So it's just more erythema, and then it breaks down, and there can be these crops of ulcers. And these ones, interestingly, do like keratinized mucosa. So this is just a little chart, okay, for summarizing that, and really good for you to just kind of remember all those little things. These 3 categories, vast majority are minor. Some heal without scarring, some heal with scarring, okay? Makes for like a really good MCQ question to ask whether you know the difference between them, right? Okay. So anyways, I don't know if you want to just like spend some time like looking at that. Okay, so again, really typical, this is interesting chart done by Prof with some data quite a while ago, but it's not surprising that majority of patients get ulceration on places like the labia mucosa, the buccal mucosa, and lateral parts of the tongue. So the soft squishy bits, okay, and that's because majority of people get minor RAS, which likes non-keratinized mucosa. So what they look like if you can catch them. So next time, those of you who get RAS, you can try to predict that you're going to get one and start taking selfies, okay? So what happens is like there's a patch of mucosa that usually probably gets scratched, so you accidentally like bite yourself, and you're like, damn it, I'm going to get an ulcer. And then sure enough, there's like a tingle, or maybe you won't even know, but there's a tingle and it feels really different, okay? So the ulcer doesn't erupt right away. But sure enough, it gets redder, and then this ulcer pops up, okay? And that usually happens over a couple of days. So there's different types of severity, and Scully, I don't need you to memorize A, B, and C, it's just that Scully split it into these 3 categories. Christmas Scully was a phenomenal leader in oral medicine, and he passed away from bowel cancer last year. But if you read a lot of oral medicine stuff, you will see many of he writes just and lots of commentary, lots of opinion, and Prof knew him very well. So, but he was describing that in terms of classifying people in severity, you have people who get a few crops of ulcers a few days a year, for a few days, a few times a year, and it's not really a big deal, okay, and that's majority people. Then you've kind of got these other people who might have episodes where they're getting quite a few days of ulcer. It's beginning to like kind of impact them. They're getting grumpy. There are quite a number of days in a month where they might need to change their diet or avoid anything really salty. And then those are other people where they've pretty much got an ulcer in their mouth all the time, okay? And another way of splitting severity is looking at things as being simple and complex, okay? And this category is probably much more important in differential diagnosis with some other types of conditions we're going to talk about next. But most people have sort of like very simple disease in that it's just the mouth, don't get any ulcers anywhere else, they don't feel unwell, it's not a big deal, and then there are those who get persistent lesions and lots at a time, and it's really causing them considerable distress. Okay, so this is more of like a binary classification, whereas Scully's was more of a categorization, more of a spectrum. So what's important about the diagnosis is that it's made based upon clinical history. Okay, so really typical of ulcers cropping up and going away and leaving no scar, causing nuisance. The important thing is to make sure that it's nothing else, all right? And everything else is everything that we've talked about so far, and we'll be talking about, as well as some of these rarer diseases we're going to talk about next. Now, you don't need to biopsy, okay? But sometimes we might, and we might because we want to rule out other important differentials, and that may be because they present with major apathy, like big ulcers that just could be something else, like pemphigus. Okay, so majority of the time, a ulcer, a biopsy is not going to give us a whole lot. But if you do, what you'll see is that the skin is broken and it's covered by goo. Okay, skin's broken, covered by a layer of random bits of dead stuff. And you will see lots of like mixed inflammatory infiltrate there. So nothing really unusual. It can look just like any other non-specific types of ulceration. But the one thing that we tend to see is that if you biopsy it at the right time, you will see more neutrophils. Okay. Now, that's not very useful because it doesn't differentiate it from other types of more serious aphthous-like ulceration. So it has to be put together with other signs and symptoms, and histopathology in itself is not going to lead us to the diagnosis of recurrent aphthous ulceration. It's more going to rule things out, okay? So particularly, so I'll just harp on about this, but particularly with an ulcer, I would be wondering from the pathologist is, do I see a split? So am I seeing what we talked about last time, or am I seeing a subepithelial or intraepithelial split, suggesting an immunobullous condition, okay? Or when I sent for this ulcer, I would definitely send adjacent tissue, which would be submitted for direct immunofluorescence, we've talked about last time, to see if there's any antibodies there. So those are the tests that we probably would be biopsying for, and questions that we're asking, not specifically, is this a aphthous ulceration? Okay. Now we're going to talk about modifying factors. So these are not what's causing the disease, but making it worse, okay, which is slightly different but important to know. And we'll talk through these really quickly. Okay, so can many people relate to how this person feels, but maybe not with textbooks because no one uses textbooks anymore. So you do it on your laptop. He does have a keyboard though, very old school. Okay, so it's really typical that people undergoing a lot of stress and pressure will have a flare of their recurrent aphthous ulceration or stomatitis, and so student years represent the highest level of RAS outbreaks. We think that trauma, so like things that can, parafunction can provide a source of trauma that might predispose to the formation of apathy if you are someone who gets apathy. And what we sort of understand is it's not going to be like a big crusty bread that, like a, sorry, I shouldn't say crusty bread, like a hot piece of pizza that's going to lead to an apathy. It's probably going to be something really silly, like you accidentally scratch yourself with your toothbrush, or you accidentally catch your lip just lightly. That sort of minor trauma appears to be more related to apathy formation rather than really big trauma, okay? Some people find that it clusters around particular phases of the menstrual cycle, and that that association may be improved with regulating the menstrual cycle. So again, this is I do not want you to take home from this that everyone should start smoking. That is not what I'm saying. But it is found that in general, smokers tend to suffer less RAS than non-smokers. It's probably something about the way that the skin gets toughened up from all the heat. Okay, but often when people who have a tendency to get RAS are smokers and they quit smoking, they may find that they get more, and that's really frustrating because, you know, it's a discouragement for them to quit smoking, but that is something that we definitely see. Okay. The whole talk about B12 deficiency is very interesting, and so probably B12 is a treatment option that I would employ quite early as a systemic option compared to something that is going to immunosuppress in these types of patients, because there have been some studies that have shown that supplementing for B12, whether or not the patient is deficient, seems to be associated with a reduction in RAS. Okay, so that is an option for somebody who is not doing that great with just using symptomatic control and needs something a little bit more. Zinc deficiency was all the craze to be tested for in like the 70s, and the problem with zinc testing also is that it's quite unstable in serum, so it's sometimes you're not getting a very good proper measurement. It's actually a false low result. So there has been a trial of multivitamins as prophylaxis for RAS, and there was no evidence behind that. So at the moment, we do not recommend that, taking multivites just because someone has RAS. We don't know, it doesn't pop up in specific areas where someone might have a contact allergy. So it's not sort of appearing specifically on areas that might touch, say, a denture or a restoration. It doesn't seem to do that. But there have been associations with people who have a tendency towards allergy, or the term that uses atopy. And there seems to be, for some people, an association between certain foods, particularly strawberries and types of fruits, vegetables, and nuts, and possibly cosmetic ingredients. So the question about sodium lauryl sulfate, which is a foaming agent that's found in everything from shampoo to most toothpaste, and it's like so I hate SLS, and it's probably because I always tell my patients not to use it, and so I just use like an SLS-free toothpaste. But when I do use an SLS-containing toothpaste, which is just like a supermarket toothpaste, I just find it awful. But most toothpaste actually have this stuff in it, and it just like foams up in your mouth. You think about the same foaming agent that you use in like lots of like your shampoos. So I think that it does actually just irritate any broken skin, and it may not be specific to RAS. It irritates in any dermatoses. It's one of the things that I'll be like, let's just get rid of that soap agent because it's probably making the mouth more dry. So my opinion with this is I don't think it's specifically related to RAS. Probably irritates people who have an aphthous ulcer when it's present because it burns and it's soapy. Okay. So next we're going to talk about are some conditions, some of them that you may have seen, well rather you have seen, and some that you haven't, and the ones you haven't we're going to talk about today. So these are some conditions that you would have heard me saying, aphthous ulceration, aphthous ulceration. So aphthous ulceration can be associated with lots of systemic conditions, including some that we've talked about recently. And when they appear in these diseases, they often don't look any different from when they appear in idiopathic recurrent aphthous ulceration. Okay, so bear that in mind, and histopathologically as well. So sometimes if you biopsy aphthous-like ulceration in, say, someone who has Crohn's disease or ulcerative colitis or even lupus, it may come back as nonspecific ulceration and not be typical of what's expected for those disease processes. We're going to talk about Behçet syndrome first, okay? Now, Behçet syndrome is the highest prevalence of Behçet syndrome is in Turkey, or specifically Anatolia, which is where my holiday photo comes from, and that's where I feel like it's one of the most amazing places on earth, and they've got these amazing rock formations which look like fairy houses, and so that's where they have the most Behçet syndrome. Now, Behçet syndrome is actually a type of vasculitis, so it's inflammation of the blood vessels, right? And it can affect both big and small blood vessels, those of the arterial or venous system. Okay, it's equal prevalence in the sexes, and it typically onsets around the same age as RAS, okay, and maybe a little bit later. It's found not only in Turkey, but along what we call the Silk Road. Okay, so we can definitely see it in Eastern Europe and the Middle East. It's much more common. There is a HLA association, HLA-B51, which suggests probably a hereditary nature, but not a strict inheritance pattern. And not everybody who has HLA-B51 has Behçet's, but it is something that can be useful to help get to a diagnosis. Okay? We don't know what causes it. And just to stress again, the ulcers look exactly the same as aphthous ulceration, and histopathologically they are the same too. So despite Behçet's being a vasculitis, you don't actually necessarily see any vasculitis on a biopsy of a aphthous ulceration in Behçet's. Okay, so that's not the special test for it. There is no special test. Okay, and so it's the key for the disease is that people get oral ulceration. Almost everyone gets oral ulceration, and almost everyone gets genital ulceration. Okay, so those are kind of the two things. Mouth and genitals are the ones that tend to be really highly associated with. They may have other types of inflammatory conditions, such as those affecting the joints and the eye, and cutaneous signs as well. Important differentials include immunobullous conditions, because you can get other types of ulceration. So that is a reason why, if we saw that, we might want to biopsy it. And in some spectrums, it can very much overlap with Crohn's, because Crohn's disease can affect any part of the digestive system, but it can also have extra gut manifestations, such as seronegative arthropathies, and it's associated with things like psoriasis itself. Okay, so there can be sort of real, almost like an overlap. They tend to be like systemic inflammatory conditions with many overlapping features. So they are very serious diseases, typically seen by rheumatologists, but you might be the person who picks this up in someone, especially if someone has that heritage. Okay. And again, they are managed hopefully with some interesting medications initially that you wouldn't really expect for ulcers. So colchicine, does anyone know what colchicine is used for? Yeah, it's used for gout. Does everyone know what gout is? So gout, yeah, you get like uric acid crystals in your joints, really, really painful. And gout's kind of considered like the disease of like the prosperous, okay, because it's caused by too much eating and drinking. So anyways, colchicine has also become very useful to help with ulceration, and that is actually what we often employ for RAS as well. Dapsone is actually an old anti-malarial, anti-leprosy agent, azathioprine is immunosuppressant, and thalidomide was actually used for, thalidomide has a very bad reputation because of its strong association with birth defects, but it is still used to help with as an anti-inflammatory. It was used as an anti-emetic when it was known to cause birth defect, when it was then found to cause birth defects. And of course, we have our anti-TNF alpha biologic agents. Okay. So I also want to mention, it's really funny because when I was like updating this lecture, I wanted to make sure that some of these things exist, because when you talk to people of older vintage who are in oral medicine, they will also quote all these really cool acronyms at you, and also like syndromes, but actually over time many of those syndromes have actually been reclassified. So mouth and genital magic syndrome is one of the, I think they just like that acronym. So magic syndrome is one of those diseases where it was sort of thought about that there might be this separate entity which includes Behçet-like presentations in combination with relapsing polychondritis. So chondritis is inflammation of the cartilage, and so that's an example where the cartilage of the ear has become very inflamed. And so some people might have these two diseases together, and they were actually thought maybe they've got this condition called magic, but what they're actually describing is that nowadays is that those two conditions should really be pulled apart and managed separately as concomitant disease as opposed to a syndrome altogether. There's another really mysterious condition called PFA-PA, okay, and that is, it's a kidney disease, And the key with this is that the kids are getting aphthous-like ulceration, but then they get really unwell for a few days when they do get it, okay? And that's probably as much as I really want you guys to know about it, that can happen, and particularly we've seen little kitties who are experiencing that. And how, like, annoying must that be for their parents, because how many times would a child come home with like a sore mouth and feel unwell, and they'd just be like, what's going on? So this is something that can also be considered. Importantly, it tends to fade away, okay, over time. Patients tend to undergo spontaneous remission, but just cause a lot of grief, rather the disease causes a lot of grief and stress for the kitty and parents while it's there. Sweet syndrome is another syndrome which has aphthous-like ulcerations. Probably won't see a lot of these patients because they will present with a cutaneous rash, and so therefore they're much more likely to present to a medical doctor or dermatologist rather than seeing us or seeing an oral practitioner, but it is something that has to be considered. Typically they're very unwell, okay? But it has to be sort of considered. The reason that is important is because it can often be associated with a malignancy. Okay, so 50% of the time it's actually related to a malignancy which should be identified. Okay, and in particular we see a lot of neutrophilic infiltrate in the oral lesions, but that's, again, as mentioned, that's kind of doesn't really differentiate from an aphthous ulcer. Okay, here's some nice apathy in Sweet syndrome. Okay, and then the last, so it used to be called Reiter syndrome, but Reiter syndrome really referred to a reactive arthritis, which is an arthritis that's set off due to infection, in combination with conjunctivitis and urethritis, so inflammation of other sites, including the joints, eyes, and urethra, okay? And so, again, very unlikely that they will be presenting to oral practitioners in the first instance, but it is something that might be considered, particularly patients are having rapid onset of arthritis and joint pain in combination with oral findings. Okay, so let's talk about what we can do to help our patients. So the reason why I'm sort of diving really right into this is that in oral medicine, we definitely don't need to manage all patients who have RAS. In fact, many patients will be seeing you and you'll be offering them some treatment options. If someone, has issues that they are having trouble with ulcers, they may say, what can I put on it? You may suggest some things. If they're having trouble and the simple options are not working, that would be appropriate for referral, okay? So we don't need to see anybody who's ever had an ulcer in their life. Probably if you have exhausted the simple over-the-counter things that you are comfortable with advising, and making sure of course, that you are modifying local factors, okay? So making sure they're keeping, their teeth clean, which you're going to do anyways. Make sure there's not like a really jaggedy tooth that's always scratching an area that's leading to aphthous ulceration. Watch out for parafunction, all right? So maybe that might suggest that maybe they are a bruxist, and you might want to talk about getting them on something like a splint. So we're going to talk about some options, some of which you might want to adopt in your future practice, okay? So for those who just want a bit of symptomatic relief a few times a year, a lot of these easy solutions are very useful. So you might suggest something like just using like a numbing gel, okay? And you might use a gel, or you might use a lozenge. So lozenges are just like the ones that you use, strepsils, when you have a sore throat. One thing that's really a quick clinical tip is xylocaine 2% gel is very expensive. But if you call a compounding pharmacist and ask them to do a 3% gel, it's much cheaper, okay? It's just because this is patented. All right, so that's a tip in case someone would like that. They can go and get like a batch made of 3% or 1% gel, whatever they would like, but that will need to be on a script, okay? So you can sort of make friends with your local compounding pharmacist and just like call them, hey, can you do some of that viscous gel for me? We don't have them like Xenox in Australia, unfortunately. Solaraze is had some trials done, but it's also used to strip actinic cheilitis. So I'm not really sure if that's something that many people would be comfortable advising patients to do. So I probably stick with these easy ones first. My favorite thing is probably just getting someone to use something like a chlorhexidine gel or mouth rinse, okay, which just keeps everything really clean. Chlorhex gel is good because it just sort of coats the area. It's a bit, I think, a bit over the top to use antibiotics for this. Yep.
Sorry, does the SLS in like some of those things?
The SLS in some of these.
SLS in like some of those.
No, there shouldn't be any SLS in those, but some chlorhexidine mouthwashes have alcohol, so that's what I definitely avoid that. Yeah, they don't, some of the other novel mouth rinses, which are not chlorhexidine, have a lot of menthol in them, and that is also very stingy on broken skin, so just watch out for that. Menthol is like what's in deep heat, okay? You can get some over-the-counter, really low-potency topical corticosteroids. I'd even say something like a, I didn't put it on here, but like a 0.5% hydrocortisone, the one that you just like get off the shelf for skin. That's okay too. So all you do is just like a little dot, okay, on the sore spot 2 to 3 times a day. Hold it in the mouth for half a minute and spit the excess. These are some of the other ones that we might get them on if they're really having trouble, but those need to be on a script. So you probably won't be prescribing those yourselves, but that's something that we might use. And of course, for really big ones, sometimes we inject them, which is no fun for anyone, but we inject them and so that they'll go away, okay? But of course, that doesn't stop the next one from coming. Here are some other topical inflammatory agents which have been mentioned in the literature. I've had some patients on cyclosporin mouthwash. It's expensive, it tastes gross. So there are lots of people doing very creative things out there, okay, but we don't use most of these on a daily basis, but they are mentioned in the systematic reviews. So physical treatments, most of the treatments that are used actually try to change the aphthous ulceration into a traumatic ulceration, so like kind of just kickstart and let it heal from there. So you can have cautery, you can just like, you can use things like laser ablation. Surgical removal just seems completely overkill, but these are some things that have been talked about, okay? The key with, I guess, a lot of these things are like, do you really want to have that done every single time you get an ulcer? So it's probably more about helping individuals who are having a real problem with their ulceration. And then we go on to systemic management, okay? So my favorite would be just to start high-dose B12 sublingually and see if that makes any difference. And we might use something that's more of a symptomatic control, such as using a like a minocycline or tetracycline-containing mouthwash. We've got some really interesting, I've just written here because it's from a review, but multivitamins have been shown not to be very helpful. And we've got some really interesting other things that we've seen in the literature, yeah.
What's
High-dose B12, like 1 milligram, or 1,000 micrograms, yeah. Yummy. Okay, and then of course there's immunosuppression, where we're actually doing some modulation to the immune system, which is not what we would go to first. And I'd say our favorite would probably be colchicine, and then next we'd maybe go to dapsone and pegtoxyphylline. Thalidomide is actually quite effective at helping with ulceration, but it's got lots of side effects. It can cause nerve changes, and also, you know, if you're trying to prescribe that in a female, they actually need to have a pregnancy test every 3 weeks. So I don't know who, I actually met a lady in Sydney who was willing to do that though, because it really helped her ulceration. She was in her 40s and she's like, this is absurd that I need to do a pregnancy test, but basically I need to do it every 3 weeks to confirm that I'm not conceiving. So yeah, there's a few options that we use there if needed. Okay, we're almost done with this section. Okay. The last thing I want to tell you about is a condition called mucositis artifacta, which is a term that I have coined as I like to, and I will explain why. Okay, so what we're seeing here is a patient who has a 1, 2, 3, 4, 5, 6, 7 unit bridge, okay, but they're all joined together, okay. Some lovely work that was done in Southeast Asia She's actually not class 3, but she bites like that because she's been posturing for it for so long, and that's just what she does now, okay? And she definitely had a history of mental illness, but not significant enough for us to feel that she was doing anything on purpose. And what she presented with was she was mainly concerned about the pain around her gums. And when you asked her where it was sore, she'd sort of point up around the gums into these areas where you can see this ulceration sort of looping, and the papillae's gone here and there, but then perfectly fine here. And what you will also notice is that there's not really a lot of erythema here. Okay, it's just kind of like not really there. So there's different types of self-injury. There might be types of self-injury that people do because they have a compulsion, so it's like a habit, and they feel that they need to do a particular movement, whether it's facial or other, that they might be doing something out of compulsion. But it might be a type of OCD, it might be a type of compulsion, not necessarily OCD, that they're actually concerned about cleanliness, which was the case here. So shortly before that, she was told by a dentist that she needed to clean her teeth, and she was demonstrated some pixters. And so she was actually getting right in there, like really getting in there. And the more that her teeth hurt, the more she cleaned, because she thought it was an issue of cleaning. So it was actually kind of compounding things. And my treatment for her was like, just stop that. And in fact, for a while, I banned her from using pixters, because for a while that got better, but it was just this one spot she kept using the pixter in, so I banned her from using it and gave her like a Monodex syringe that's only allowed to squirt water through it, and we finally got that better. The real cause of her discomfort was probably actually parafunction related dental alveolar, because she's actually just pushing. We made like a little guard for her, and she's like really happy now, but she was worried that she was actually that her teeth were dirty. So can be compulsion, not necessarily a actual disorder, but a concern, and then someone doing something despite it not being helpful for them. Patients can also have a delusion and not be aware about it. So we have met patients who have, for lots of different reasons, but they believe that they're infected, and they start to pick at themselves because they think that there's like a bug inside them, or like a bacteria or something, and they do come in and they show us things that they've brought in. They're like, here are the bugs that I pulled out of myself. So that can happen, and those are conditions where they're not aware of what's going on. And then we have the other types of self-injury where a patient might be aware that what they're doing is harming themselves, and it might be out of an expression of something like anxiety or expression of stress. And that's why it is important to consider whether, if you see it in a child, whether it might be representing that they do need help and that they're actually undergoing some sort of type of abuse. And then the last category, it may be that they're doing it for gain. Okay, so for types of syndromes where the patient probably not purposely choosing to have this mindset, but feels that they will be better off if they are sick or unwell or seeing doctors. And it's only when we see that we do call it factitious injury, because the word factitious kind of means like made up, all right? And so I don't really like it when we use the term factitious injury to talk about this, because it most of the time it's actually not factitious. It's more, it could be any of these other things. So my preference is to use the word artefacta, which means artifactual injury. And there is a term that's called dermatitis artefacta. So on the skin, when people do it to themselves, it's called dermatitis artefacta. So I probably prefer us to use this term. So I'm introducing it to you guys now, and have done so too in some talks to other dentists. Okay, so that's the breakdown of why we say that. And here she is after she's just kind of chilled out a bit, but a little bit red there, but much better. Okay, still doing that weird protrusive thing. Alrighty, this is not an ulcer, okay? This is an injury, which is a type of lemur.